Let me start with Dr. Sarabjit Chadha, who has recently joined FIND as the Regional Technical Director based in India. Professor Kirtan Dida from the University of Cape Town. Dr. Titus Divala from the University of Malawi. Dr. Hamida Hussein from IRD Global. And last not least, Dr. Nestani Tugwadze from NCLTD in Georgia. Thank you, everybody, for joining us for this important discussion.
Can I ask, first of all, for just the panelists to address where do you think your top 3 priorities are for systematic screening or case finding in your own country? And I think, let's, if we can put those on the table first of all, and then we can manage a discussion around that.
So, with respect to targets for active case finding?
Yeah, your top 3 priority populations or clinic.
So, in Malawi, the national program recognizes the key priority populations being the contacts of TB patients and close contacts as well, and also those patients that are in people that are living in high density urban centers, and also populations that are patients that are presenting to health facilities, and people living with HIV presenting to clinics are also promoted by both the HIV program and the national TB program. So those are the sort of high priority populations in Malawi.
I think it's quite similar in India. India is a high TB burden country, and what we've seen is, that the urban slums, household contacts, and prisoners, are the 3 top priority groups. But of course, India being a large country, there is also a lot of variability in terms of prevalence of TB, and so the scenario changes. It also depends, how the transmission is happening and what are the healthcare services available. So it may not be like written in stone that these are the top 3 groups, but these could probably change, with province to province or district to district.
I don't know if this is working. Yeah, so I think I had pretty much the same 3. I put community-based active finding in these peri-urban informal settlements or slums as number 1, because that's really where the bulk of the missing cases are, and that's where most of the transmission is happening. Second was healthcare facilities, and thirdly I put down contacts of index cases, but I think focusing on this community-based burden is a priority because that's where all the transmission is happening, and if we're really going to impact the epidemic, that's where we need to be looking. I mean, you raised the question of what diagnostics, what do we do now, and what do we do later on, but I would just like to suggest early on, to park this for discussion later, maybe we should be talking about embracing a new paradigm, and that's taking the diagnostics out into the community. And, in the HIV field, we have HIV self-testing. Why can't we think about TB self-testing? And Claudia mentioned in the context of the existing diagnostics, the different levels. But maybe beyond level 0, we need a level -1, right? You take the diagnostic out into the community. It's available in supermarkets or kiosks, in pharmacies. You can buy it, and you can go home and you can test. Okay, and I think some of the, if you look at Claudia's, listen to her talk, some of these things are now tangible, right? These lateral flow assays and the signatures on simple platforms. You can, it's tantalizing, but you can envisage a scenario not too far into the distant future where you could buy such tests. So I think the paradigm would be moving diagnostics out into the community. The question is, how do we do that now? Do we use things like Expert Omni and other things, and CAD, as you said, and what do we aim for?
Yeah.
So in Pakistan, we follow pretty much what you guys have already discussed, so I'll not repeat that. What I would like to add is, as IRD, what we have tried to focus on is make facility-based screening our priority, and those are low-hanging fruit. People are already approaching the facility for symptomatic